Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today, we are here, as always, answering your COVID questions live. We've been getting lots of questions in, so you can go ahead and put questions that you have directly into the box below on either Facebook or Twitter. You can use the hashtag AskDrArwady. Today is Thursday, February 17th, 2022. Those of you who have already been on Google might have noticed that they've changed the Google top line to celebrate what would have been the 94th birthday of the man who invented the chickenpox vaccine and did a lot of important vaccination research. So I was happy to see that when I looked at that today. As always, let's look at our COVID dashboard to start with. Chi.gov/COVID- will show you what's happening in Chicago. And first of all, really pleased to see the progress in cases. That 389 cases per day. Yes, it's down 31% from a week ago, but more importantly, for those of you who have been following along, being back under 400 cases a day moves us from the high risk category, as it has historically been defined by CDC, et cetera, into the moderate or substantial risk category. It also marks us being below 15 cases per 100,000 per day. You can see on the right here, we're at 14.4. So really pleased to be back at that level. Hospitalizations continue to fall, 31 new hospitalizations every day in Chicago compared to 57 new hospitalizations per day in Chicago. Just people continue to ask about the difference between that and hospital capacity. Under here, hospital capacity will tell you how many people are in the hospital. This is about new hospitalizations on the main default of the dashboard. Why is this not? So if we look at deaths, those are still relatively high but falling, between 7 and 8 a day on average now compared to 12 a day a week ago. Vaccinations down a little bit to averaging about 6,000 new vaccinations a day, although the percentage of people vaccinated continues to go up, of course. And we're doing 27,000 tests a day. Our positivity, because tests are going up, 4% from a week ago. At the same time, cases are going down, 31% from a week ago. Our positivity has also fallen to 1.9%. So let me just go ahead and pull up the slides here. All right, so first of all, on our risk matrix, as you see, the cases diagnosed per day have dropped from that high transmission. Everything was very high in red just a few weeks ago. And now we've seen cases fall from high to substantial, which is very good because the positivity, as you can see, is actually all the way down in low, sort of controlled, less than 2%. And so given that we've seen the positivity get all the way down to that low transmission, one of the reasons that cases can still be higher is there's a lot of testing going on. And so we sort of look at those two in combination. So really pleased to see cases all the way down in substantial again, and then positivity down in low transmission. Hospital beds also decreasing really nicely. These are the 7-day averages at 292 for hospital beds and 102 for ICU beds. I do think you can see 102 there is pretty close to 99. I wouldn't be surprised probably tomorrow even if we've gotten down into that blue category there. And I'm hopeful that by early next week we will be at a point where at least 3 of those metrics are in blue, are in lower transmission. So continue to be really optimistic about the way that is heading. Of course, that's what we're looking at, where we're thinking about being able to drop indoor mask requirements, et cetera. I wanted to highlight that the breakthrough data is now available on our website. I shared last week, I think, that you can already download all of it through the data portal. Sometimes we have people who like to do their own assessments, but we've got the graphs up now too. So as a reminder, breakthroughs is what do we see related to cases, hospitalizations, and deaths in people who are vaccinated here in Chicago. Separately, we also follow reinfections. We've seen a lot of those, but the breakthrough data, which is one of the things that we need to follow long term, because if we were to see a lot of breakthrough particularly hospitalizations and deaths, we would be concerned about the vaccine potentially not working in the future, right? This is one of the things that we always monitor, even for flu. We monitor when people are admitted to the hospital or they die from influenza, were they vaccinated or not? Was it a good match? And so just as a reminder on this, the red is the hospitalization rate for unvaccinated Chicagoans, whereas the light blue are people who were fully vaccinated but not boosted, and the dark blue, people who are both vaccinated and boosted. And so you see during this Omicron surge, this is kind of December and January here, when we had more people hospitalized in Chicago with COVID than we have ever had. Going all the way back to the beginning of COVID, the huge majority of that was red here in terms of the rates of people who were unvaccinated being admitted to the hospital. And we did see some increase, but not a big increase in hospitalizations for those who are vaccinated and boosted. You can look overall. You can also look by age group. We've got age-adjusted, crude, it's all in there. And you find this on the dashboard when you go up to the top, latest data. In the same way, second down here is the community transmission and risk. That's the matrix. We're updating that every day. Around midday, after the day's hospital numbers come in, right here is where you can find the Chicago COVID-19 breakthrough data. It's all graphs. You can manipulate the axes and encourage you to explore that as you would like to. This is where you can also see the latest on variants, wastewater, a lot of things folks ask about, hospital capacity, doubling time, the portal are all here. Just as a reminder, the vaccines do really continue to work beautifully, especially against severe COVID outcomes. Where we look at infection rates just in Chicago, they continue to decline. I shared this at the press conference on Tuesday, but our age-adjusted COVID infection rates were 3 times greater in unvaccinated Chicagoans compared to vaccinated boosted Chicagoans. Our hospitalization rates 10 times and our death rates 30 times over that whole time. And the vaccination rate does continue to increase. 76% of all Chicagoans have now had a first dose, 68% fully vaxxed, and 81% of age-eligible Chicagoans, 5+ have had at least 1 dose, 73% fully vaxxed. Much of the world is quite a bit higher than that, in particular in Europe and the UK, but we are making progress and certainly doing reasonably well for the U.S. in terms of vaccination. And these numbers do continue to go up every day. This is from the website. And we do see thousands of people getting vaccinations every day. We are almost to 50% of our 5 to 11-year-olds having had their first dose. We're at 49.6 compared to the U.S. average of 31.8%, and we're at almost 80% of 12 to 17-year-olds in Chicago having had at least a first dose, compared to about 2/3 in the U.S. You can see the completed vaccine series on the right is lagging that a bit, not a surprise, given that always lags by a few weeks, and we sometimes, not everybody gets their second dose, but making good progress there. Of course, children remain by far the least likely to be vaccinated, though, and that's been one of the concerns in school settings. We also hit this important benchmark of finally passing 60% of Black non-Latinx Chicagoans having had a first dose of COVID vaccine, 54% fully vaxxed. That's a benchmark we've been chasing for a while. So thanks to everybody who's helped get us there. We were aiming for 50, hard if I think back a few months ago, and now we've crossed that 60. You can see still continues to lag between white Latinx and Asian Chicagoans quite a bit, but catching up. And given that we saw this Omicron surge hit Black Chicagoans so much harder, especially on severe outcomes, hospitalizations and deaths, we continue to focus on this. We're still seeing a lot of good uptake, especially in our at-home vaccination program among Black Chicagoans. Our community partners, the Healthy Chicago Equity Zone leads, are working hard. We've got our vaccine ambassadors out going door to door in the least vaccinated communities, making sure people have information, know how to get treatment, know how to get testing. Also, I did want to share, I shared this on Tuesday, but you keep sending me a lot of questions about how is CPS doing, so I wanted to just share, because we didn't do this on Facebook, that just as expected, in line with City of Chicago data, the COVID-19 cases in Chicago public school buildings continue to decline, though they remain above pre-Omicron levels. They have these as the week starting date, so that's the farthest one on the right here is the week starting February 6th and last week in essence, and that was already down 60% compared to just 2 weeks ago. We are seeing the same pattern in non-public schools. We are seeing the same patterns in the community. Not a surprise, knowing that with the mitigations in place, we don't see schools be a major source of increased risk. It primarily reflects risk in the community. So that is good. And similarly, CPS breaking all records for testing. So the number of screening tests last week, over 64,000 tests, more, about 10,000 more than they'd ever done. And in that setting, the screening test positivity continues to decrease. You can see it was down under 0.5%. Now, we're not surprised to see that test positivity be lower than the city positivity because these are screening tests. These are people who are in school, asymptomatic, presumably, or they shouldn't be in school if they're having symptoms, as opposed to people who are presenting with symptoms, coming in to get tested, et cetera. But nevertheless, this is what we would expect to see, cases going up, positivity going down, and you compare that less than 0.5% positivity to just a few weeks ago, 2.5%, you see before that 5.5%, and going back to the holiday time, about 19%, although of course school wasn't in session. This was a relatively fewer number. And then the record number of screening tests, the test positivity is back to being lower than it was since early November. You can see overall the test positivity in CPS has been just under 2%, and last week it was down to 0.45%. And in comparison, Los Angeles, over the last 7 days, their public school system had a screening test positivity of 1.3%, and New York was down to 0.35%. So again, very consistent with seeing Omicron. LA is a little bit behind in terms of coming off that surge, but everything continues to look very promising in the schools. Also, CPS doing a really good job on vaccination. There have been more than 700 plus dedicated sort of pop-up vaccination opportunities at the various elementary and high schools. This is just this week's to give you a sense. So like today on Thursday at Clark High School, Ash Elementary, Darwin Elementary, Hendricks Elementary, King Elementary, Hughes Elementary, Morales Elementary, Niños Heroes Elementary, and Sherwood Elementary. And these are the times, in addition to 24 school-based health centers and the regional clinics at the big high schools. So certainly schools continue to be a place we're doubling down on, lots of work with having those conversations, building that confidence, and thanks to everybody at CPS who is working hard at all of these schools to continue to make sure people are getting vaccinated and that we are keeping everybody safe. I also just wanted to reiterate, because we got some more questions about the early treatments that are available for COVID-19. Reminder, if you test positive, regardless of vaccination status, you should reach out to your doctor, to your healthcare provider, if you have an underlying condition or if you are over 65, just full stop. Because these can help keep people out of the hospital, but you have to take them in the first few days of infection. And really what we're hearing from our providers here is there are more of these available than are being used. And that is primarily because in some cases people are on other medications, et cetera, and they're not eligible for them. But also the main problem is they're hearing from people who would have been good candidates too late. So please, you are not bothering your doctor's office or your healthcare provider's office if you let them know that you've tested positive for COVID, and we want you to do that if you have underlying conditions or you're over 65. You do need to be evaluated. These need to be prescribed by a healthcare provider. You can't just get them off the shelf. But I did want to emphasize, just based on some questions that we'd gotten, all individuals over 65 are eligible. They are provided by the federal government at no cost. CDPH has worked to make sure federally qualified health centers in particular are able to access them, know what's available. Hospitals have them. We started, of course, making sure long-term care facilities and some of the hospitals that treat cancer patients, we especially want to make sure the highest risk people have access. But as the supply is built up, there is increasingly, there's availability in the outpatient setting. It might still take some extra work, but we've been working hard on the provider side so that they know how to get you connected. But the first thing we need you to do is make a call and see if your doctor thinks that this is something you should do. So we got lots of availability for our family vaccine clinics, CDPH's clinics. Saturday, we're at Kennedy King. Sunday, we're at Olive Harvey. We continue to do hundreds of vaccines at these events each weekend. So we're happy to do adult vaccines, pediatric vaccines, booster vaccines. As always, chai.gov/COVIDvax or 312-746-4835. I got a question in today as you're thinking about being able to lift mask requirements soon, can we still get vaccines at home? Yes. The city of Chicago remains very committed to continuing our Protect Chicago at Home program. Anybody in Chicago, you do not need, the question was for homebound seniors, but you don't need to be a homebound senior. You can be any age, and we will bring a first dose, a second dose, a booster dose. There are incentives around the first and second doses, but we would love to make an appointment for you Monday through Sunday, morning, afternoon, or evening. Give us a call, and that program is not going away because we want to continue to make sure people are getting vaccinated. And then finally, I got some questions in about this slide that I had shared at the press conference that we did on Tuesday. A lot of you have been asking about risk and, is COVID over? Why are we still doing things? And I just wanted to share a little bit about how across the country we think about risk and why there are still mitigations in place in certain settings based on data. And so this was as of Tuesday. At the current case rates in Chicago and Cook County, still an estimated 45% chance, 1 in 2, that at least one COVID-19 positive individual will be present at a 50-person gathering or event. So that does not mean that we will see transmission at that event because many more people are vaccinated. Especially folks who are vaccinated often have very mild symptoms. They're wearing masks, they're distancing, et cetera. So it's not that we see transmission, but I want you to realize that there still is a reason, there are still quite a lot of people who have COVID in Chicago, even if they don't know it. There's about a 69% chance, again, this is statistically, if everybody had this, there's assumptions in this, of course, but at a 100-person event made up of random Chicagoans, about a 69% chance. And then at about a 500-person event, you can basically guarantee that there will be at least somebody who has COVID. And so some of you were asking about, where does this come from? What is the ascertainment bias? And so I thought I would actually just click on this and show you. This is just an example of one of the, it's trying to load. There we go. So this is an example. These are standard estimates that are used across the country, but I like this one because it's interactive. The way it works is you can hover over the county that you're interested in. So for Cook County, for example, here, it says the current risk level is 41%, and about 70% of folks have immunity via vaccination. So that 41% risk level means for an event that of a given size. And in this case on the right, you can see this is for an event with 50 people. But you can play with this if you want to. So you can come down here and say, I'm not interested in a 50-person event. I'm interested in a 25-person event, more like the size of a classroom, right? And then this ascertainment bias has to do with how much COVID are we missing? How many people are not might have COVID and are not getting testing or not having symptoms? Here in Chicago, we have good testing, and so I would put the ascertainment bias really at the lowest point, sort of at an ascertainment bias of 3. And so at 3, in a 25-person gathering, and if you come back and hover, it's about 18%, less than a 1 in 5 chance at this point, but still about a 1 in 5 chance that in a a gathering of 25 people, one person would have COVID-19. Those numbers continue to drop as the numbers come down, but this is some of the way that we look at data to then make assessments of risk and say, we're at a point where when gatherings are happening, it's less, the risk generally is low enough that we're not needing to include masks, et cetera. So let's go ahead and turn into some of your questions. All right. Oh, I like this. Vicky Trinidad from Facebook calling out Chicagoan. She says, we've made great progress, my fellow Chi-Town folks. Keep it up. Please continue following preventive measures. Thank you. I agree. I really am so pleased by the progress. I'm pleased that we've not seen the subvariant of Omicron, which you remember there was a lot of worry about. We've not seen that. Significantly slow progress. We are almost down to these lower risk levels, which when you look at the science, you look at the estimates around what control that suggests of COVID, we will be at a place where we can start really dropping some of this, and we're really close, and it is really exciting. And a big thank you, I can't echo that enough, to Chicagoans who have gotten us this far. Okay. Oh, apparently someone's just telling me my screen didn't change when I went to the website, so nobody saw it. So sorry about that. The link at the bottom there will take you to the website, and I encourage you to explore it. And I'm sorry that didn't appear. If you've got other questions about it, let us know, and we can bring it back again next week. Okay, so Nixon's Goatee on Twitter is asking about a graphic that Dr. Luna had shared, and there's data in the hospital capacity data table that are in the lower transmission tier in 3 of 4 metrics. Why the discrepancy? Yeah, really good question. I know that was an issue yesterday. So when Dr. Luna had made her slides for yesterday, they were made without the 7-day average. When you pull up just the default there, it's today. It's always like what has been reported in this day by the hospitals. But we have situations where a given hospital sometimes misses a day of reporting or is delayed in reporting. And so sometimes you'll see, like trust me, I follow this very closely every day. And we had, I think even yesterday, we had a day that was only showing, I think, 71 ICU. And I was like, wow, that's really low, like much lower than what we would expect. And we found out that 2 of our large hospitals had not gotten their data in on time. We have a team behind the scenes that goes and cleans that. But in terms of following this, we follow the average. And so you can find that if you on that exact same place where you're looking at hospital capacity, you can go and hover. But also, if you want to see the matrix of where we are officially, please use that drop-down data from the data tab at the top of the dashboard. So really good question. And that's why we're close, not quite there, but almost there. All right. So Paul Maurer on Facebook, why are daily case counts still a critical stat you're using around determining mask and vaccination clinics? It's clear from the past waves that case incidence doesn't directly translate to strain on the healthcare system because of increased vaccination numbers and success. Yeah, this is a really good question, Paul. So I agree with you that cases and positivity are not the most important thing, especially at this point. That said, cases and positivity do give us some of the earliest indicators of when we start to get into trouble. By the time you start to see people getting into the hospital, getting into the ICU, dying, those of course are lagging indicators. And so so there's a couple things for this. One is, as we come off this surge, I remain very committed to making sure that we are following CDC metrics, and CDC metrics do still include the cases and positivity. You've heard us say we've got to get to 3 of those 4 metrics, recognizing that those case numbers, I agree, they do not mean as much as they used to, honestly. But they remain the way the CDC sets those figures, and I think they're appropriate because still, that number of people is circulating in Chicago with COVID. And that's sort of the difference between the risk and what I was saying. The risk of transmission is lower among those people because more folks are vaccinated while they're masking, et cetera. But please know that we don't magically see hospitalizations and deaths start to surge without having seen cases surge. And so as we are moving ahead in a more long-term way, sort of coming off Omicron, if you remember last week, one of the reasons I brought our epidemiologist on who does influenza surveillance was to talk about how I expect we will be transitioning to sort of all of the ways in which we follow cases, but we don't count every case. We do count severe outcomes, hospitalizations, ICUs, et cetera. We do tracking across emergency departments that doesn't need to be individual level data, but lets us know when are we seeing surging of people coming in with the type of symptoms that suggest respiratory viruses. We obviously collect samples from across the city to look for strains of influenza, aka variants of COVID. So yeah, you will be seeing as we come off this surge and hopefully move into more of a sustained, relatively controlled state for a while here. I do expect you'll be seeing some of those change, and CDC has signaled, and we have been part of those conversations, signaling that there will be some ongoing change there. So I don't think, we've never counted every case of COVID, just to be clear on that. I've been saying that for ever. But that's where that ascertainment bias comes in a little bit. There are places that do very little testing for COVID, and you know that in those settings, their case rates are actually quite a bit higher than they are in truth. And there are places like in schools, right? That 0.45% positivity is different because there's a lot of testing, but it's of asymptomatic people as opposed to across the whole city. Of course, most of the people getting COVID tests are getting them because they're concerned about an exposure or they're having symptoms. So certainly, we continue to follow these metrics. They have served us well. They are the national recommended metrics and they fit in. But I think as we come off of this Omicron surge, as we lift these restrictions, we will be primarily looking at, the severe outcomes are the ones we worry about. But one of the things that we've really seen, what we saw in Omicron, was that, you do need to act. Like the WHO has been looking at how things have gone. And, the fact that we had more people hospitalized here in Chicago with Omicron than ever before, that's not great, right? And yes, most of those people were not vaccinated, but nevertheless, it put huge strain on the health system. We had to cancel elective procedures. We had, 24, 48-hour waits in some cases for people to be able to, get care. And you've got to make sure you have some early warning signs for, and we had the mask requirement in place. We have the vaccine requirement for those high-risk settings. Those are for the more severe outcomes. So we are getting close to them, but the 3 out of 4 requirement is partly recognizing that in my mind, too, those have changed. Two of the metrics are the severe outcomes, and the third is that combination for me of the cases and positivity. And Jeff Hutchins, kind of in follow-up on Facebook, will the mask mandate in Chicago be lifted when state bans are lifted on the 28th? I hope so. So as I said on Tuesday, we will be standing up next week and making the final call on that. I am feeling optimistic toward that. What I've said is that we've got to see our I need to see 3 of those. I want to be clear that these decisions are made based on this data. This is what we do, it's what we've done all along, and that data in turn is based on risk. Where we've said we're willing to be flexible is that if the timing, is slightly different, I don't mind if we would be hitting this, 3 days later, 4 days later, 1 day earlier. It's not worth the confusion. So we will be making a formal announcement early next week and let folks know one way or the other. If it is not the 28th, it won't be long after, would be my expectation. My hope is it can be, but we got to see the data get there. That's just how it is. So I hope that clarifies it, and we're getting really close, and that is thanks to Chicagoans. Okay, let me hit. So Riz Scully on Facebook has put in a couple of questions here that I really want to address because I'm thank you for raising them, and I'm a little concerned about them. So. Riz, you write, many highly vaccinated countries are asking people to get HIV tests. It's probably because they made the vaccine with part of the HIV virus and people are starting to get AIDS now. And then you also put, why are so many people getting autoimmune disorders question, in parentheses, AIDS after the vaccines. So thank you for raising this. This is misinformation. This is not true, and I want to really explain why that isn't true. And I would love it if you would send me what you're reading there, because this is exactly the sort of thing that I like when people raise, because I want to be able to address it and let you know that's not true. So first of all, the vaccine is not made with part of the HIV virus, full stop. In fact, the vaccine is not even made with part of the coronavirus. The Pfizer and Moderna vaccines have no virus in them at all, of any kind. They just have the instructions to teach your body how to fight off the virus. And then the Johnson & Johnson vaccine has what's called an adenovirus, which is a very common cold. It doesn't make people sick at all. That's been altered to not make people sick. But there is no HIV virus, and in fact, no coronavirus in the COVID-19 vaccine. Nobody is getting AIDS, I promise you, as the result of getting COVID-19 vaccines. And no country anywhere in the world has linked COVID-19 vaccines to HIV, to AIDS, or to recommendations. It is and has always been a recommendation in the United States that everybody over the age of 18 should get an HIV test at least once, because we know that there can be people who get infected with HIV and don't know it. And so as a primary care doctor, I know the recommendations for screening. In the same way, at certain ages, you screen people for cancer, you also should get a screening at least once for somebody for HIV, even if they're not reporting risk factors. So we definitely recommend that people get HIV tests. We especially recommend that if they have been known to have an HIV exposure or they have other risk factors for HIV, but it's a universal recommendation. It has nothing to do with coronavirus. And to your question about why are people getting autoimmune disorders, in parentheses, AIDS after the vaccine. So first of all, autoimmune disorders is not AIDS. AIDS is the manifestation of having had the HIV virus for a long time. Autoimmune deficiency syndrome, it's a specific thing. Autoimmune disorders are a big category of disorders that just mean in some way your immune system is attacking itself. But autoimmune disorders is not the same as AIDS, and we have not seen upticks of people getting vaccinated, and that we certainly have not seen it with AIDS, full stop, and we have not seen a big increase of people getting a vaccine in an autoimmune disorder. What you may have been reading, if you think back to the Johnson & Johnson vaccines, where there was this slightly increased, I mean very slightly, but still it was there, increase for the blood clotting issues, if you remember, that was probably an autoimmune process that we can occasionally see, not just from, I mean, we see it in COVID infection too, not just in vaccine, we can see it in other settings. So that's an autoimmune process where the body can sort of attack its own cells, but that is not AIDS, and that is not a new autoimmune disease. We have not seen people getting new autoimmune diseases as a result of the vaccine, and there is no link at all between HIV and coronavirus or the coronavirus vaccine. So thank you for raising that, and do send along whatever you were reading about that. Okay. Don Wolf from Twitter. This is kind of funny. He says, you've returned to the theater, frequented restaurants, and you've even gone to a bar. I can tell you're a frequent watcher. Will you continue these activities once vaccine and mask requirements are dropped in Chicago? And he says, by the way, what's your drink in case someone wants to send one over? So yes, I will definitely continue these. Everybody, and I took the question partly because I want to emphasize that everybody is going to have different perceptions of risk and worry around their own underlying conditions, their families, who they live with, whether they're interacting with people who are not vaccinated, et cetera. And so for me, I have obviously felt very comfortable returning to doing the things that I love doing in Chicago. I have felt even more comfortable, to your point, being in places like restaurants and the theater, and yes, even the bar once, because I knew that during this surge, there was this requirement for vaccination in those settings. And even separate from that, the theaters, et cetera, have made that a recommendation. But I want to make clear that once vaccine and mask requirements are dropped, the reason they are dropped is because the risk is low enough to drop them. Is the risk zero? It is not. It will probably never be zero. I don't think we are ever going to eradicate COVID. But the whole reason we don't just arbitrarily choose a date and just drop drop mask or the vaccination requirements. We do that based on data, because as those data numbers come down to a point where we are at lower risk, that truly means we are at lower risk. It's the same as last summer as we were coming, when we first were able to enter actually phase 5, right, without the mitigation in place. We had a period there where there were not indoor mask requirements, right? There were not additional other requirements. And the mask requirements only came back when we saw numbers come back up to a point of higher concern. That was all pre-variants, but the risk doesn't change because COVID transmits in the same way, even with variants. I think we've seen the Omicron in particular be so much more infectious and so much more transmissible. So that gets balanced against the fact that we have a lot more people vaccinated. We're not seeing the severe outcomes. So this is another reason why, we've continued to follow some of these same metrics. But even with a more infectious variant, knowing how much more testing there is, knowing all these factors in, I feel confident that when we lift those requirements in Chicago, it is no longer a requirement to have masks in indoor settings in Chicago. There likely may remain a mask recommendation, and we will probably continue to see individual settings, or we may, continuing to require them. There will also continue to be requirements in certain settings. For example, transportation continues to be a requirement set by the federal government right now for masking. So on the subway, on the bus, on the airplane, right now, you would still have to wear masks because that is being set at the federal level. There are also separate requirements in places like nursing homes and healthcare settings, and that's absolutely appropriate. There are also certain examples of times. So remember how we've shortened the isolation and quarantine to just 5 days? If somebody has been diagnosed with COVID or they've been a close contact and they're not vaccinated, they got to quarantine for the 5 days. Remember, it's the 5 days you got to be home. Days 6 through 10, you can be out and about, but still with a mask. That doesn't necessarily go anywhere, right? And so the lifting of the mask requirement is about saying the risk has come down enough that, broadly speaking, in indoor public settings, there is no longer a requirement that everyone wear masks. But there still will be requirements in some higher risk settings, and there will still be recommendations. There will still probably be some businesses who decide to keep it in place, which is fine if they want to make that decision. When we drop the mandate, we don't put something in place that says you cannot have masks in place. And depending on the setting, depending on the people, there may be individual settings that decide to continue that. That won't be a problem. But I think as people get more comfortable with it, if our numbers stay down, if things seem good, I'm hopeful that we won't need to require them again. However, we get into trouble in the future, a new variant comes, things start really surging, we start threatening healthcare systems, we probably would need to require it again. So the hope is not, but we will do it based on the data, and that's the best way I know to protect this city while keeping all the things that we love going. So yes, I will be out, and I'm not going to share my drink because I'm a government employee and I never want people to think that they could influence me by buying me things. So, but people do come up to me all the time actually when I'm out. Most of the time people are kind, and I appreciate that. Thank you. Okay. All right, so I see Andrew B. here, who had sent some questions and has posted this question about Comernarty. So he says, if Pfizer's own insert for Comernarty states, quote, safety and effectiveness for children under 16 has not been established, what evidence trials have you seen? How can you determine children should get injections, et cetera? Okay, good question. Let me clarify this. Comernarty or Comernarty, I don't like Pfizer's name for this, but I think you're supposed to say it Comernarty. In any case, reminder, newsflash. Comernarty is the brand name for the Pfizer vaccine that has the full approval. All of these vaccines have been under emergency use authorization, and then to get full FDA approval, to be able to name a vaccine, name a vaccine something like Comernarty or what's Moderna's name? It's escaping me, but we'll get it. When you name, Spikevax, that's what it was. So Pfizer got the full FDA approval for over 16, because that was its first trial. And so Comernarty specifically in the package, the one that they can advertise because it's not in EUA anymore, is 16 and up. However, all of the data, all of the trials, everything about the safety and efficacy for kids is fully available. You can look it up on the FDA, you can look it up on the CDC. We've shared links to it. And that safety and efficacy has been 100% proven. It is part of the EUA. The difference between an EUA and the full approval is that takes many more months. It includes things like the FDA doing the investigations of all of the manufacturing facilities where these are being made and signing it off. And the only big difference is once it's fully approved, you can, the pharmaceutical companies can advertise around it directly. Doctors can write for it for reasons other than what it was authorized for. That's really not very relevant for a vaccine, but sometimes it's relevant for a drug. And so please know that although Comernarty, the brand name, the insert for that would be for 17 and up. The insert and all the information around the Pfizer vaccine for kids under 16 is all there. It's just that it's not Comernarty because it doesn't have the full approval yet. So thanks for that question. Okay. BMats131 from Twitter. Hi, doctor. Why do you continually push for people to vaccinate their children for a disease that poses no harm to children? So, good question. I wish that this disease posed absolutely no harm to children. It poses much, thank God, lower risk of harm to children. That said, are there children who have died of COVID-19 in Chicago? There are. Many, no. But are there some? Yes. To a similar number to what we see die from influenza? Yeah. Have we seen children get admitted, hospitalized with COVID? Definitely we have. And the being unvaccinated is the biggest risk factor for that. So I certainly have some concern for children themselves, especially if they have underlying conditions. But we even saw healthy kids in a few cases get admitted to the hospital, seriously ill, even die. And that is not common, thankfully, but it is also not anything. And vaccines help protect against those severe outcomes. Vaccines also are the most important thing that can help protect against infection. And so given that, again, not commonly, but we see children occasionally develop this MIS-C, this multi-inflammatory inflammatory disease, multi-system inflammatory disease that is not common at all, but it's really serious. It puts kids in the hospital, and it's not about vaccine, it's about disease. The potential for long COVID in kids, we're not seeing it a lot, but we're seeing it some. So of course, if we're gonna give a vaccine, the recommendation and the reason the CDC and all the advisory panels weigh in on this is they look at the risk and the benefit. And they see that there are real risks for kids of getting COVID infection. Things like that myocarditis, pericarditis that has gotten a lot of attention. The risk is way higher when kids get infected with COVID-19 that they can get that. There is, than there is getting it with a vaccine. And so you do a risk benefit and you say, thankfully, the risk is lower in kids than it is in adults, but it's not zero. And very clearly, when we're not seeing safety concerns, et cetera, the risk-benefit analysis is literally what it's called. It comes down very strongly on vaccine. But for me, it's much more than that, because kids, it's not just about them individually. It's about the settings that they're in. So if you think about in schools, there are kids in schools who have severe immunocompromising conditions, even if the child themselves doesn't. And we know that when others are vaccinated, they are less likely to be infected with COVID also, right? And so having a more highly vaccinated setting helps protect the more vulnerable members. And there are more vulnerable children. There are kids on chemotherapy, et cetera. And then finally, those kids don't only interact with kids, right? The kids interact with siblings who are too young to be vaccinated. The kids interact with adults. The kids interact with grandparents and older relatives. And although the kids themselves may not get seriously ill, we certainly know that adults do all the time. And so for me, and the reason all of the children in my life, I have said vaccinate right away, is that I don't worry about a child who's been vaccinated getting seriously ill with COVID. I don't worry a lot about a child getting COVID, getting seriously ill, but if they're vaccinated, like, the chances are minuscule that they're going to get seriously ill. And I've seen that even in my extended family. If a vaccinated child gets COVID, like, they barely know it, right? And so I'm thinking both about the individual child, the fact that they are interacting with vulnerable other children, and that having a more highly vaccinated population decreases the risk for everybody and gets everybody through it. So I make the same recommendations to you that I make for the children in my own life, and that is my answer. All right. Diane Ponder on Facebook. I have an art opening tonight. Is it better to limit time at the reception? I'm boosted and will wear a mask. So, I can't make those individual level decisions all the time for you, but I took it because I want to tell you how I would think about this. So first of all, I'm guessing that you, as somebody who's boosted and will wear a mask, you take COVID seriously, so that's good. You've done the most important things in terms of preventing yourself from getting sick, and everybody will be wearing a mask, assuming it's in the city of Chicago, because at least for the next few, couple of weeks here still, give or take, that everybody will be wearing a mask. I'm not somebody who has serious underlying conditions. I've vaccinated, boosted, et cetera. As you heard, I have been out and about and being careful. I think anything that, quote, limits time will decrease your risk. But for me, when I think about limiting risk, it would be more about, is everybody else masked at this setting? Can I keep that mask on, right? Like, maybe I wouldn't eat or drink if you wanted to be sort of extra careful, would probably be the specific recommendation. And if it's generally in a, open space, I would say you can go to the art reception. You've done the most important things, but keep the mask on, and maybe don't eat and drink while you're there, is probably the most modifiable thing that you can do. So, good question. Namrata Batra from Facebook. Can kids go back to cloth masks in school if they were using KN95 for Omicron? So this is another good question that more has to do with individual risk and comfort. Do you remember what I said all along with this? The most important thing for masks is that you're wearing one that fits your face well and that it's comfortable and you can keep it on. I don't find the KN95s as comfortable as I do the surgical masks. That's just me. And I like to be able to trade out the surgical masks because you can easily see if they're getting soiled, et cetera. I might put a cloth mask over top, but I still wear a cloth mask sometimes, et cetera. I think about KN95s as being especially, this is me personally, being especially important at times of greater risk. So yeah, during Omicron, one of the reasons CDPH worked to push a bunch of KN95s out into communities where we knew there were people who might not be able to get them or might not be able to afford them even though they're available, is because at a time of increased risk, putting a possibly less comfortable mask on helps decrease that risk. Your own protection is better when you are wearing a higher quality mask, right? But we have never mandated or required that a certain type of mask be worn. So you have to wear a mask. It can be a cloth mask, it can be a surgical mask, it can be a KN95 mask. For me, if I'm getting on an airplane, if I'm gonna be in a setting where I know there's a lot of people, it might be less controlled, I might put a KN95 mask on, right? I have them in a number of colors now. I bought them on Amazon, you know. But if I'm just in my sort of regular day-to-day, I'm back to, for the most part, wearing surgical masks or sometimes even cloth masks. And that's just about sort of as numbers go up and down. So you can make that decision. There is not a requirement about the specific type of mask in school. We work to make KN95s available. And I know CPS, for example, has them available for staff and for students. But there's not a requirement around a specific type of mask. The biggest jump that you get, remember, is keeping your germs to yourself. Your germs to yourself. And the barrier is the most important thing there, even with cloth. Some of you remember from back in the early days when I used to show the studies of this, those sneezing studies that show what happens with germs, you know, from nothing to the cloth mask to the surgical mask to the N95 masks. You see an enormous decrease in germs leaving with that cloth mask. And then you do see slight improvements with those higher quality masks. But especially for kids, I mostly just want them wearing something that that fits their face well and that they can keep on. Chris Wilder from Facebook says, Spike Vax is best name ever. Yeah, I mean, this is not an official opinion. I do think that, Moderna had a better name there than Pfizer did. But in any case, Spike Vax, just like Comernarty, are the brand names that they can now have for vaccines that no longer have emergency use approval. Okay. The Gray Ghost from NYC on Twitter says, 2018 hospitals were so overwhelmed with flu patients, they were being treated in tents in parking lots. How can the public health order be justified if we have yet to exhaust methods previously used to mitigate overwhelming hospitals? Okay, so I'm not sure you mean 2018. 2018 was not a, I mean, it was a bad flu season. Maybe you're remembering H1N1, I don't know. But we do sometimes use things like tents to take care of people. We have set up mobile morgues here in Chicago, like during COVID, to take care of all of the unexpected, not unexpected, but the much larger number of deaths and hospitalizations. But is it my preference to have to take care of really sick people like in a tent? Of course it's not, right? And some of the reason, you know, when early on we had to set up McCormick was because we had truly seen capacity get overwhelmed, like in New York. If you've not read about what happened in Italy, in New York, in places that historically have not had problems, like seeing a healthcare system overwhelmed is unbelievably scary. I'm a doctor, right? I have worked in healthcare settings. Also, when I was in Liberia for Ebola, for that outbreak, I saw that healthcare system get overwhelmed. I saw it entirely shut down. People, literally, there was nowhere to take people with car accidents. There was nowhere to take people who needed diabetes medications. Women couldn't go to the hospital to have a baby. I mean, like, not that we would sort of get to that extreme, but this is not a sort of theoretical risk. And it's also not just, the biggest challenge, honestly, especially during Omicron, it's not like, can I set up a bed in the tent? Because we did that in Liberia, let me tell you, like setting up all kinds of stuff. It's about having the staffing. And if you talk to people who work in hospitals, especially people who are seriously sick, if you need to be in the ICU and on a ventilator with COVID, which hundreds and hundreds and hundreds of people just during Omicron have had to do right here in Chicago, you need a lot of care. You need a lot of very specialized experience, the doctors, the nurses, the respiratory therapists, et cetera. And you can't have like a tent full of people on ventilators and like one person taking care of them. That's not how it works. And so when we think about overwhelming our healthcare system, we think about the personnel that are required, we think about the space. And McCormick was never going to be the place for the ICU, if you know what I mean. It was sort of meant for lower level, you know, folks who have COVID, maybe they just need oxygen, but they don't need to be ventilated, et cetera, partly to make sure that we're trying to keep some space for people who have everything else. But the public health order, you know, we had, as I said, more patients hospitalized with COVID during Omicron than we have any previous time. But that was partly because people who were supposed to get other treatments, they were scheduled to have non-emergent surgeries. Those all got canceled. That we had people waiting a lot longer for care, getting delayed. That also has consequences. You know, when we release just shortly, we've just gotten some of the early mortality data back, and when we look at what has happened with COVID, certainly we've seen a ton of people die of COVID, but we have seen a lot of indirect effects too, right? We've seen more people dying of cancer. We've seen more people not having their diabetes controlled. You know, people not able to get the care, not going in to get the care. This is all part of the same system. And so let me tell you, you do not want to live somewhere where the hospital system is at a point where we're having to treat seriously ill people in parking lots, because if that happens in December or January, like, we got problems. Renee Harkey from Facebook, will a fourth dose be required? Not at this point. If you have had, the recommendation is if you had Pfizer or Moderna, you got your first 2 doses, you need to get, or you should get a booster dose at least 5 months later. If you had J&J as your first dose, you should get a booster dose, ideally of either Pfizer or Moderna, but you can get J&J if you want to, 2 months later. So if you've had 2 doses starting with J&J or 3 doses starting with Pfizer or Moderna, you are entirely up to date. There are, I think that where people have gotten confused, there are people who have more severe immunocompromise where there have been some recommendations for additional doses. That is not because, that's because they don't mount the same immune response to the initial vaccine. So that's not something you need to do on your own. You would be talking to your doctor who treats your immunocompromise or your cancer, et cetera, about that. But there is no requirement for a fourth dose, no recommendation at this point. And I can't promise for sure what will be happening long term here. It all depends on what happens with variants moving forward here, honestly. We see another bad variant emerge. We see vaccine efficacy wane significantly, especially against severe illness. Could this become something that's an annual recommendation like the flu shot is? We could. We're not there yet. But you are up to date if you have had all 3, and there is no recommendation or requirement for a fourth dose. Okay. All right. We are at time, but I want to just highlight that today is also National Random Acts of Kindness Day. And I would please encourage everybody, as we approach a moment where we're going to be able to lift some of the COVID mitigations that we've been under for a long time, and there are people who are nervous about that, understandably. Please, it is going to be a time to be kind to each other, patient with each other, recognizing that, yes, it's a huge moment of celebration to be in a point where COVID has receded to the point where we can lift these things. I'm thrilled about it. But it's not a light switch either. It's not that all risk for COVID has completely gone away. It's diminished to the point that we don't need everybody doing some of the more difficult things. But there are people, many people, who are older, who have underlying conditions, who have people in their family who aren't vaccinated, who continue to be concerned about COVID, who feel nervous about taking off masks. We're gonna see people still wearing masks, and we're gonna see some people not wearing masks. That is fine, that is healthy, and that is not something to be fighting about as we move ahead here. So please, today, National Random Acts of Kindness, but I'm not gonna say random. I'm gonna say please, over these next few weeks, Remember, everybody wants to be done with COVID. Everybody wants to be done with COVID. COVID is not done with us, but we are at a point shortly where it's going to be safe enough to lift some of these requirements, but we're still going to be following it. We get into trouble again in the future. I can't promise it's never coming back. And in the meantime, people are going to continue to make those decisions about what kind of mask should I wear? Should I go to this art opening? How worried should I be about this situation? That's appropriate, it's good, and we need to be kind to each other, okay? Thank you. We will be back on Tuesday. We are planning to bring Dr. Erica Taylor on. She is one of the medical directors at CDPH who's been leading on a lot of our outreach around Black Chicagoans getting vaccinated. And obviously, I know people are going to be watching some of those metrics closely. I have asked our epidemiologist to come in over the holiday weekend to make sure that we get at least one update of those numbers, knowing that there is a lot of attention on what's happening with mitigation, and we want to be able to make a formal announcement about that next week. So please continue following the dashboard, continuing being kind to each other, and we'll be back with you to answer your questions next Tuesday at our regular time. Bye-bye.